So good morning, dear colleagues. We will start this session with adult spinal deformity. And here are disclosures. We'll start with mechanical complications and the risk of mechanical complications, especially in the setting of degenerative scoliosis when you instrument to the pelvic, to the pelvis and the sacrum. We know that pseudarthrosis is one risk. On the long term, PGK and PGF is an issue, and screw loosening as well. Now, in order to drop the risk of pseudarthrosis during the last years, four-rod instrumentation, the use of interbody cages became more and more popular. But on the other hand, on the mechanical side, this could produce some enhanced stress at the top end and the lower end of the construct. And because of that, there could be a higher risk of PGF, screw loosening, and PGK. So we wanted to look in a multi-center study from a register what the influence of implant components was, depending on the number, type of rods, number of screws, the number and type of cages used, but also we looked at patient-related factors and sagittal alignment. So register data was used from several centers across Europe, and we had quite a homogeneous type of instrumentation from the lower thoracic spine to the sacrum and pelvis, so quite a homogeneous population. Sagittal alignment was assessed, the number of vertebrae was assessed, obviously, and then specific data on the implants type and number of rods, type and number of cages, and also the density of screws used. Complications were monitored clinically and radiographically, and also on CT and SPECT-CT if rod breakage occurred or if pseudarthrosis was suspected. In total, out of the register, 302 patients were eligible. The age was quite homogeneous as well, around 65 years, predominantly females, and approximately 22% had osteopenia or osteoporosis, which was documented. Now let's first have a look at the complication pseudarthrosis. The pseudarthrosis rate was 24.1%. Let's have a look on univariate and multivariate analysis and what the influence of age, patient-related factors, and alignment was. Actually, there was no major influence in univariate analysis, so we did not carry on with multivariate. Let's have a look now more specifically at the implant-related factors, and you can see that the predominant influence was by double rods. So using four rods would decrease the risk for rod fracture, at least in the short term, a 2-year follow-up. A third of the patients had a longer follow-up, over 5 years. And cages played a role, but this was not significant, so this was really a secondary role. The other interesting finding is that if you use more screws, a higher screw density, this will not prevent you from getting a pseudarthrosis. The PGK rate was 19.2%, and here was the other way around. Patient-related factors and alignment were really the predominant thing that would drive the risk of PGK. So alignment and higher age were the main predictors for getting a PGK. On the other hand, implants were not influencing the PGK rate, and having a stiffer construct would not influence that. Finally, screw loosening without PGK, the rate was 8.9%. There was no patient-related factor that would influence that. And the only factor that we found on the implant side was if you use a lower screw density, this would increase the risk of screw loosening. So just as a summary, pseudarthrosis, the rate can be dropped down using four rods, but knowing that in the long term this needs to be verified after 5 years. Cages have a secondary role in load sharing, but high screw densities also does not have a protective effect. On the other hand, PGK, PGF is mainly driven by alignment and patient's age, and screw loosening is mainly linked to screw density. Thank you.